The title of my talk is Imaging the Heart, the New Frontier. And what I want to start off is by telling you that there are continuing developments in medical technology as well as clinical research that's expanded the role of imaging as well as diagnostic measurements. Nowhere is this true more than in cardiology, where the choice of investigative techniques include different methodologies which have overlapping capabilities. What I am going to do over the next 45 minutes or so is to show you some of the recent trends in the cutting edge technologies that we use to image the heart. And I also want to take you through the different achievements and the progress that we have made in this specialty. So cardiovascular disease is essentially the number one killer in the Western society. What does the term mean? And very simplistically, what cardiovascular disease means is the disease that affects the heart as well as the blood vessels. So it not only includes things like heart attack, but also stroke. On the other hand, heart disease is a term that's like a catch-all phrase that includes diseases that are specific to the heart. This comprises of diseases that you may be born with, or you may inherit as a result of a faulty gene, or go on to develop it later on with age. And we will look at various types of heart disease in this presentation. Now, when we look at the heart, the technology that we have allows us to explore different facets of the heart. I'm going to ask you to take a step back and go to your school rooms where we studied a little bit about the heart. And what I can remember from it is very simple, but it still stands the test of time. The heart has got three vessels. These are called the coronary arteries, and they run over the surface of the heart. Anything that's going to block the blood flow to the coronary arteries is going to result in heart attack. And this essentially is coronary artery disease. For those of you who are fond of Radio 4, this morning they talked about a publication in this month's edition of the British Medical Journal, the BMJ, where they said women in the UK are twice as likely to die from heart disease as they are from breast cancer. So this is not a rare disease, this is present and it affects men and women. And also affects young people. We have about 40,000 people under the age of 75 who suffer from cardiovascular disease in the UK in 1 year. Now, this is a naughty diagram, but it does tell you what you need to know. So the heart has got essentially 4 chambers, and the blood comes in from carrying the waste products from the different parts of the body and enters the right side of the heart. It then gets into the lungs where the blood is purified, and the oxygenated blood then enters the left side of the heart where it gets pumped into the systemic circulation, and it supplies the rest of the body including the brain. So the next set of diseases that we need to think about is defects where there is something wrong with the plumbing, or you have holes between the chambers, and this results in a group of disorders that get called congenital heart disease, and these are essentially birth defects. If you move on, the heart is essentially made up of muscles. It's a very muscular organ. And these muscles help in contracting the muscles of the heart, help in contractility, and help to propel the blood to different parts of the heart. If you have a diseased heart muscle, you get this condition called cardiomyopathy. It's a generic term, encompasses a wide variety of conditions, and I'll show you some as we go along. There are 4 valves in the heart, 2 on the right and 2 on the left. And these valves are essentially like flaps. They allow the blood to flow through in one direction. You don't want blood to backflow because you don't want admixture of oxygenated and deoxygenated blood. And this kind of pathology that affects the valves of the heart is called valvular heart disease. The heart has got complex network of electrical pathways, and if something goes wrong with that network, you get rhythm problems. The commonest rhythm problem is irregular heart rate, which is called atrial fibrillation. Finally, there is this very generic term called heart failure. This essentially means the heart is not capable of pumping the blood with sufficient force to supply blood to different parts of the body. Now, when you think about heart attack, very simplistically, the reason why you have heart attack is because of a series of events that lead to it. And essentially, a normal blood vessel that you see on the extreme left has got blood flow without any obstruction through the lumen of the vessel. With time, for a variety of reasons, you get different components such as calcium, fat, cholesterol accumulating initially in the wall of the vessel and later on encroaching into the lumen of the vessel. The more encroachment there is, the tighter the narrowing of the lumen, the more difficult it is for the blood to pass through. Now, what happens is if some of these materials form what's called a plaque, and the plaque with time will harden the arteries and clog the blood vessels. When small areas of fat come off the plaque, then you get injury in that area with blood clot formation, and this is what results in a heart attack. Unfortunately for some people, this can go on and stop the heart from beating, and that's what is called cardiac arrest. In the UK, out of hospital cardiac arrest, there are about 30,000 of these that happen, and about 1 in 10 survive. So it's very important to recognize that we all need a little bit of cardiopulmonary resuscitation training because it's a relatively common thing to happen. I'm going to not bore you with statistics, but I just want to tell you 2 or 3 things. Every minute in the UK, every day, someone goes to the hospital with symptoms of heart attack. And every 8 minutes, someone dies as a result of the heart attack. We have about 7 million people who live with this disability. And this, as you can imagine, is a substantial burden for the healthcare. Now, I'm going to move on and I'm going to tell you something which I love history, and the history of cardiovascular imaging is actually fascinating. We have known for centuries what the heart looked like, and we've also known for the best part of 400 years what the circulatory pathways are. So Leonardo da Vinci was fascinated by the heart, and he made a lot of statements about the heart which we are finding out today is actually true. He was the first one to say there are 4 chambers to the heart, and you can say so what, but remember these are the times before microscopy. He was able to say that the heart is a muscular organ. Moving on, we have William Harvey. He was a graduate from Cambridge, and his thesis was on the circulation, and it's called De Morte Cordis, and he proposed that we actually have 2 circulatory loops, one supplying the right side called the pulmonary circulation and one supplying the left side called the systemic circulation. But you have to realize this happened centuries ago, but modern cardiology and imaging actually was born in the beginning of the 20th century. So this is the very first image of cardiac catheterization. This image was published in 1929, and it comes with a very, very nice story. There was a 24-year-old German resident doctor called Werner Forssmann. He was dealing with problems to do with the urinary bladder. And he thought, can I use the techniques that I'm learning here to directly deliver drugs to the heart? Thought about it for a few days, and one fine day decided to put it into action. So he takes a urinary catheter, gives himself local anesthetic, feeds this 65 centimeter long catheter up his arm through the vein and goes to the heart. He then carries this catheter up to the radiology department and takes this picture. His superiors looked at this, they were gobsmacked, and they thought this was a stunt. And they told him that they will expel him if he carried on doing any of these stunts. He stopped there, but what he was smart enough to do was to write up his experiences and get them published. Few decades later, this was recognized and he got a Nobel Prize. So we have a good start. We then move on, the story moves over to the United States, to Cleveland. There's a professor who's in charge of the cardiac catheterization lab. His name is Mason Sones. And Soames was doing a catheter with a couple of his fellows. And by accident, when he was injecting the dye, the contrast medium, into the cavity of the heart, the catheter slipped and went into the coronary artery. And few years later, when Soames recounted this story, he said he was watching what was happening on the monitor with his fellows. And when he noted that the catheter had slipped and the 50 mils of contrast medium that was meant to be delivered into the heart went down the coronary artery, he was first of all stunned. Second of all, he realized that the patient's heart had stopped beating. And he said his heart too stopped beating. But this story has got a happy ending. Fortunately, the patient's heart recovered spontaneously. Soames then realized that for the first time in anyone's life, you're looking at the coronary vascular bed in real time. He went on to pioneer the technique, but unlike our friend Forsman, he waited for 250 cases before he wrote up his experiences. And that was in 1958. Now we cannot function this without catheter angiography. It underpins everything that we do in cardiovascular medicine. And then you think, where can we go from here? Well, I think we tried and we produced images like this. This is a M-mode echocardiogram looking at the blood flow in the heart. This, believe it or not, is a cross-sectional image of the heart using a nuclear technique. And these kind of images were produced in the 60s and 70s. I have to say, thankfully for us, these two techniques have got refined, and I'm going to show you how they look now in a moment or so. And then we wait. In the 70s, we have the invention of the CT scan. 80s, there were techniques like the MRI and the nuclear magnetic resonance, and things got getting refined. But we had to wait until the dawn of the new millennium. And we now have this technique that is called cardiac CT. And this technique came along 2004, 2005 really, and I was fortunate enough to be involved in this technique when it was just at its infancy in the UK. And one of the reasons why this technique took off was because we have parallel advances in computer science. And these two together, the revolutionary CT technology and the computer science that it required to do that, has catapulted cardiac CT into an entirely new arena. We then have cardiac MR catching up. From 2002 onwards, I think we've started to get good images and the technology is now improving, and I'm going to show you how it's got an edge over CT when it comes to the heart. So, imaging in the 21st century, where are we now? So, these are some examples of echocardiogram. And if you remember the M-mode echo, I think you will agree we've come quite a long way. So we start off with 2D imaging. We then are able to do 3D imaging, which is the far right. We're now able to look at the pressure and the strain in the heart muscle. And previously, the machines were big and cumbersome. But now we have machines that are the size of an iPhone. These are point-of-care echocardiography machines. They weigh less than a pound. You can take them around, and these are incredibly useful in an emergency situation where what you need to know is this a medical emergency? Is there anything I can do? And so echocardiography, I think, has come a very long way. We then go on to see where are we with catheter angiography. So catheter angiography really underpins everything that we do in cardiovascular medicine, and the reason why I say that is you get these exquisite images of the coronary arteries, but you can go one step further and also address the problems that you see. So what I've shown you is a blockage in the proximal, in the front aspect of the vessel, and the cardiologist, the interventionalist, can go on and either put a balloon or a stent, and you can see that the vessel has opened up. Now, It's difficult to see what's happening inside the vessel. So when you want to do that, what you would do in order to see these plaques is to pass an ultrasound probe, and this technique is called intravascular ultrasound, and it gives you a fantastic image of the different plaque composition here. So you can see the fat, the calcium, the white bit is the calcium, the cholesterol element. So this is called virtual histology. You no longer have to cut a patient open and put a tissue under the microscope to see things like this. Having said that, it does have some limitations, and the main limitations are this technique is an invasive technique. So it requires a catheter to be put either through the groin or through the arm, and you go into the heart and into the coronary arteries and inject the dye on the contrast medium. And it involves X-rays. So there is a radiation hazard. If you were only going to do the diagnosis, then we have alternative techniques that can give you similar information. On the other hand, if you want to do it as a two-stop procedure where you go on and do an intervention, then we cannot beat catheter angiography. So what is this new kid on the block that we can use instead of catheter angiography? And that is where cardiac CT comes in. Now, I've deliberately shown you 3 different conditions on cardiac CT, but let me just take a moment to tell you what is this technology. So essentially the CT, which can image different parts of the body, has been around since the 90s in the clinical field. But we have a problem with the heart. Unlike the brain, for example, the heart is constantly moving. So we needed a technology that could image all of the parts of the heart and the coronary arteries movement free. And in order to do that, what we now do is to acquire the images in tandem with the patient's ECG, which is the electrodes that you put on the chest and follow the electrical activity of the heart. Let us say, for example, a patient comes in to the hospital casualty with chest pain. There are different causes of chest pain. What you want to know is this chest pain because of 3 of the medical emergencies that could potentially kill the patient? And these are those 3 conditions. On the far left is a condition which you all know about now. It's narrowing of the coronary arteries. In the middle is a condition called dissection, which essentially is a tear in the vessel which can spiral out of control and block the blood supply to the entire body. On the far right is a condition which is essentially called pulmonary embolism, which essentially is because of a clot in the lung and the blood vessels supplying the lung. You don't have to do 3 different tests to rule out these 3 different conditions. I can do 1 test, 1 sitting, 1 set of injection, and give the clinician the information that what he or she is dealing with is one of the 3 conditions. What does the test involve? Well, it also involves radiation, but unlike catheter angiography, it's got 2 other advantages. It's non-invasive, so I don't have to thread a catheter into the patient's heart. And most importantly, I get all of this extra information, and I get this in milliseconds. Catheter angiography, even in the best of hands, by the time you get the patient into the cath lab and out of the cath lab, you're talking about an hour. The patient then has to wait in the hospital for observation as a day case. This patients come in, have their test, and go home in 15 minutes. What about cardiac MRI? So cardiac MRI uses electromagnetic waves to detect the hydrogen in the water, which is what most of the tissues are made up of. Apart from the coronary arteries, for which CT is better, MR really has got an edge over all of the imaging modalities that I'm showing you. And it's for 2 or 3 very good reasons. The top reason is, yes, it's non-invasive, but most importantly, it does not involve any radiation. So you can look at the heart in multiple planes on different occasions without having to worry, am I really going to cause any harm? Now, it is very good for looking at the heart muscle. It's very good for looking at the heart function. It's very good for looking at the blood flow. And in the middle is a picture where you can not only see the direction in which the blood is flowing, but you can also, based on the vectors, do some pressure measurements, which is kind of the holy grail really. If you can talk about the different pressures in different parts of the heart, the patient will have a much better treatment option and does not need to undergo any further testing. This technique, this middle technique, is currently used in limited clinical situations, and I'm sure over the next few years we are going to see more of that. Finally, we've got this technique called nuclear cardiology. It's been around for 40 years. We've got a lot of data from this. It involves injecting a radio tracer, and you follow the tracer to different parts of the body. And in this case, I've used a tracer to look at the heart in cross-section. I can do this in two ways. I can either use what is called a SPECT machine, or I can use what's called a PET machine. Exciting thing about this technology is I can combine it with other technology. So in the middle, you've got not just nuclear technique, but it's been superimposed on CT. So this is called PET CT. I can also do this with MRI, and that's called PET MRI. And the advantage of combining two techniques, this is called hybrid imaging or fusion imaging, is given the rate at which this technology is evolving, I'm going to be able to look at things that are happening at cellular level, and that's going to be extremely powerful. Okay, so I've now shown you a lot of tests. How do you decide which test you want to choose from? I think two things I have to say at the offset. Availability of the test is one and convenience is the other. Patient choice also comes in, but for me, if you don't have the test, then you're not going to be able to do it, even if it's going to be the best test that is going to give you the answer. There are two components to this dilemma. The one is patient-related factors, and the other is the clinical question. So, on the patient-related factors, you want to talk about the age of the patient. You don't want to give radiation to somebody who is very young unless they absolutely need it. Gender is an issue. We know that radiation is more of a problem for women because the breast tissue is extremely sensitive to radiation. Body habitus is very important. If you've got somebody who is very big and who can't fit into the scanner, then there is no point in trying to oil them into the MR scanner. Rhythm is an issue. So if you've got irregular rhythm, you may not be suitable for a cardiac CT. Contraindications. There are some tests which have got absolute contraindications. So if you've got anything metallic in the body, you're not going to be safe to go into an MR environment. Comorbidities, it depends on what other clinical conditions the patient has got that could potentially impinge on the safety of the test that you're planning to do. Patient choice, you'd be surprised how many times the patient says, I don't want this test, I want an alternative test, and you have to respect that. The second component is the clinical question. The test that you choose depends on all of these questions. Are you actually doing the test because you want to assess a particular risk factor? Are you going to do the test in a clinical emergency setting or in a much more elective setting? Do you just want to know about the anatomy or are actually interested in the function of the heart? Do you want to look at some particular tissue? And do you want to use this test as a follow-up test, or do you want it to guide the time of treatment? And all of these will impinge on what test you ultimately choose. Now, there are some challenges, and I've already mentioned one of them, which is the heart is constantly moving. It is a very simple organ, but it's beating every second of your life. And therefore, this fluidity, this motion makes it very difficult to image something which is within the heart. The second problem I have, this is an example of a angiogram, a CT angiogram of the coronary arteries. It looks relatively big there, but in real life, the thickness of that coronary artery is the size of a spaghetti. So if you then imagine, I'm trying to imagine something that's that thin in a structure that's constantly beating, it is going to be challenging. So what do we do about it? Well, that's where we've got the innovative scanner technology. So if you have a scanner, a CT scanner, and you've placed the patient with the heart in the middle, essentially what happens in the standard CT scanner is you've got one set of an X-ray source and you've got a set of detectors. These detectors will take the X-ray beam that's traveling through the patient's body from different angles and it will reconstruct the images. You might have heard of numbers, 16 slice scanners, 64 slice, and what these numbers mean is the number of detectors that you have. And these detectors will then go around the patient to collect the data. I now have a different type of scanner where I've got two X-ray sources that are perpendicular to each other. I also have two detectors that are perpendicular to each other. And that's going to rotate around the patient. And this is what the inside of one of these CT scans look like. And you can see how powerful the intrinsic mechanism of this device is in order to be able to look at that tiny vessel in its entirety. And it can do this, as I mentioned before, in milliseconds. Right, so we'll move on to actually showing you what it is that you're trying to see. So atherosclerosis is a term that essentially means that you're trying to look at the plaque. As I mentioned before, plaques are made up of calcium but also of fat and cholesterol. Calcium is a window to atherosclerosis. That is all there is to it. And it's a very, very simple test. You don't need to inject the patient with anything. They just go into the scanner and you get this image within seconds. And what you're looking for is the amount of calcium that is there in the coronary arteries. Very simply put, if you, irrespective of your age or gender, if you have no calcium in the coronary arteries, then your chance of having a cardiovascular event is less than 1%. And there is a warranty period for this for the next 2 to 5 years. Now, this is a very, very strong test. On the other hand, the flip side of this is most people start to develop some calcium in their blood vessels beyond the age of 40. So what do you then do with that information, particularly if they do not have any symptoms? Well, that is the million-dollar question, because as yet, we don't have any studies that strongly prove that if we start treating patients who have no symptoms but who have got a lot of calcium in the blood vessels, we actually make any difference to their outcome. But having said that, if you are a worried well person and you walk in and have one of these scanners and you are told that you've got calcium, and in the future you may go on to develop significant coronary artery disease, you would want to have something done with it. So the moral is, don't have the scan if you don't want to have any treatment. Now, this is an example of a CT, which is now the second stage of the procedure where I've injected the dye. And this is called CT coronary angiogram, and that is the image on the left. The image on the right is your standard catheter angiography. And the arrow points to an area where there is significant narrowing of the blood vessel. And both tests show that very, very well. And they have a good concordance between CT and catheter angiography. But I want you to look at the vessel before the stenosis. And if you look at the CT, you can see that there is a thin rim of plaque. You can see white bits and you can see dark bits. Those are fat and cholesterol mixed with calcium. Now, if you look at the same area on the catheter angiography, it looks relatively innocent. And the reason for that is catheter angiography is essentially a luminogram. It just shows you what's inside the lumen, but it doesn't show you anything about what's happening in the vessel wall. So, we now have a technology that's going to pick up the disease at such an early stage that if you then implement the appropriate treatment, you would prevent them from going on to develop the disease which we have seen with that arrow. So it's early pickup of the disease. That's the power of this technique. Now, all plaques are not the same, and also all narrowing are not the same. So you have this discrepancy between supply and demand. When you have a narrowing, you're going to have reduced blood supply. Most of the time, in the initial stages of the process, when you are at rest, you do not have any reduction in the blood supply irrespective of the vessel being narrowed. But the minute you exercise, and that exercise could be going on a treadmill, or it could be done with the help of a drug, which is what we do in radiology, and you can use a variety of drugs, you start to see that there is a reduction in the blood flow in that particular part of the heart. And this difference in the blood flow between the exercise state and the resting state is what that gives rise to ischemia. So ischemia essentially means reduction in the blood supply, resulting in reduced oxygenation to the heart muscle. And this is why patients get what's called angina or chest pain. Now, I've done this particular test with a radioactive tracer. You can also do the same without radioactivity, and I'll show you that in a moment. But the power of this technique is, if I do the test and I have got, say, 40% narrowing, but I do this test and I have no reduction in the blood supply, the risk of sudden cardiac death is less than 1%. So the test has got a very, very good prognostic value. Now, this is the other way of looking at it, and this is doing it with MRI. On the top deck, I've exercised the patient. On the bottom deck, the patient is at rest. Now, it's not as colorful as the previous image, but it does show that there is reduced blood supply in the lower part of the heart. Why would I choose this over the other one that's visually pleasing? Well, the simple reason is this does not involve any radiation. And therefore, if I had a choice and I needed to have the test done, I'll opt for this test first. And if I can't have the test for whatever reason, then I will go for test number 2 and test number 3. Now, one of the problems that we have with MR scanner, and it's a real problem in real life, is most patients don't want to go into the tunnel. So it's a long tunnel. So if you've got claustrophobia, it gets accentuated when you try and put them inside that tunnel. Well, what can we do about it? Modern technology is wonderful. They've now come up with this kind of open design where only the area of interest goes under that magnet, and everything else is outside that area. So if you have claustrophobia, you can opt for an open magnet. There are also magnets that look at different parts of the body when you are standing up, but currently we don't have that for the heart. It's mainly lying down. By the way, this is not available routinely in the NHS at this point in time, but it will come. Now, MRI is the gold standard for cardiac function, and by gold standard, what I mean is it's the reference standard. If we say on MRI the heart function is normal, you can take it for read that the heart function is going to be normal. The reason for that is it's a test that's remarkably consistent. It's reproducible, and whether I look at it or my colleague looks at it, it is going to give you similar information. And therefore, as a test, it stands the test of time. There is no inter or intra-observer variability. What else can I do with MRI? Well, the first thing I can do is I can look to see if there is any scarring of the heart muscle. And the reason for that is heart attack, the so-called myocardial infarction, gives you scarring. And depending on the thickness of the scarring and the extent of scarring, I can then tell my surgeons or my cardiologists, this part of the heart is completely dead. Don't waste expensive technology trying to open the vessels that supply this part of the heart. Concentrate your efforts in looking at some other part of the heart. There is also in this patient a blob, a black blob, and that happens to be a clot in the chamber of the heart. These clots are not good news because they can fly off and they can go to the brain and they can cause a stroke. So once we find this out, the patient will have to go on blood thinning tablets. So it's a very, very powerful test. This is one of the commonest indication that we do cardiac MR for, to find out if the myocardium is viable. Is it alive? The next thing is, unlike the heart attack scar, once you get it, it's permanent. You can have scar which is reversible. And that happens, for example, in this condition where you get inflammation of the heart muscle. Why would you get inflammation? You can get it because you've got an infection. You can get it because you've got a condition where your body's immune system acts against you, conditions like vasculitis. And what you're going to get with cardiac MR is it shows you that there is waterlogged myocardium, waterlogged heart muscle, and it is scarred. And I can also look for scarring elsewhere, and in this case, the patient has got scarring of the layer that surrounds the heart and keeps it in position, called the pericardium. So this condition is inflammation of the heart and the pericardium, and it's called myocarditis or myopericarditis. It's getting to be one of the common indications for cardiac MR, because a lot of people have it when they have got an infection of the chest and they think it's just a lung infection, and then they have an abnormal rhythm that brings them to the hospital. We do this test and we show the infection is not just in the lungs, it's also in the heart muscle. Now, this is something that's received a lot of press, and this is sudden cardiac death. We all know someone who is happened to run in a marathon and drop dead. A common story, the newspapers cover it often. Not all sudden cardiac deaths are due to heart problems, but the majority of them are. And we can use imaging to tell you whether there is a problem. One of the causes is this condition called coronary artery anomalies. So what it is remember the slide where I showed you that you've got 3 major arteries supplying the surface of the heart. Of these 3 arteries, 1 come off on the right side and 2 come off on the left side. Should you have variations in where these vessels are coming from, you could potentially end up in trouble. This is an example of a patient where there is only 1 vessel coming off from the right side. It then goes around the heart to get to the left side. So in essence, the patient has got what we would call a dangerous coronary artery anomaly. Why is it dangerous? Well, in this reconstruction, what you can see, the arrow points to the coronary artery that's coming off from the wrong side, and it's passing through 2 chambers of the heart, one above and one below, that's the red star. And when you exercise, these chambers of the heart will enlarge. That's normal with exercise. So if you imagine you've got very little space and this tiny vessel is trying to pass between these 2 chambers, it's just about managing to do that when you don't have activity. But the minute you start to exercise your heart by running a marathon, these chambers dilate, they compress the vessel, and you suddenly have no blood supply, and no blood supply can lead on to a heart attack. So a dangerous condition. Can I tell you that it takes seconds to diagnose this by doing a CT? Literally seconds. So I suspect that people who are running, elite athletes, should in this day and age have a test like this to make sure that they do not have coronary artery anomaly. Now this is an interesting story. Another cause of sudden cardiac death. So this is one family tree, and you can see the red is bad. They've got a condition that is transmittable down the family line, and it affects both men and women. And you can see that there are some people who are affected, there are some who are not affected. The green is they haven't clinically manifested the disease, but because someone in their family, and in this case 2 of her siblings and her mother and her nephew, died of this condition, so this woman presented to us for a screening. She was asymptomatic and we found that she has the disease. Her children, one of them died, One of them has got genetic mutation that tells you they're going to develop the disease, but as yet they have not developed it. What is this disease I'm talking about? There are plenty of conditions like this, but the one that I'm talking about in this case is a condition that causes thickening of the heart muscle. And this condition is called hypertrophic cardiomyopathy. So it's a condition that affects the heart muscle, and the heart muscle gets thicker and thicker, and it's so thick that the heart can no longer contract. Now, the condition also is affected by scarring of the heart muscle, and you can see that in the arrows. And the more scarring you have, the greater is the chance that you're going to have a sudden cardiac death. Great. So you're going to tell me that whatever I do, it's irreversible and I'm going to have sudden cardiac death. So what's the big deal? Why do I need to be screened? Well, you need to be screened because now we can do something to prevent you from having that fatal rhythm problem, and that is I can put a box, I can put something called a defibrillator in you so that when your heart goes into an abnormal rhythm as a result of that scarring, the box will take over and it will sort out the rhythm so that you no longer have this danger of sudden cardiac death. There are other conditions of the heart for which we have exactly similar family trees, give or take a few differences in the way the genes are transmitted. At this point in time, we are not addressing the faulty gene. That's not the remit of an imaging specialist. All we are doing to help is if one member of the family has got this condition, it's very important that other members of the family get screened. And this is best done with MRI for all the reasons that I've said to you. It's the gold standard. It gives you all the information that you want about the heart muscle, and it's consistent. It doesn't matter whether I report it or a colleague elsewhere in a different part of the world reports it. It's going to be very, very consistent. So it's an extremely powerful technique for this condition. Now, I'm just going to move on a little bit and talk to you about this syndrome. You might have heard of it. It's called broken heart syndrome. Literally, that's the name of this syndrome. And it's something that we see in patients who have suffered an intense emotional problem, such as a bereavement. There are reports of it's a little bit more common in women, and there are reports of women having had a big fight with their boyfriends and presenting with this condition, but it can also happen in men. Now, what you have in this condition is patients present with chest pain. When you do their ECG, the tracing of the heart, it looks like they are having a heart attack. You do the blood test to look to see if they have got heart muscle damage, and the blood test is positive. So to all intents and purposes, as far as you are concerned, they're having a heart attack. You take them to the cath lab because you want to see, is there a blockage in the coronary artery? Can I clear the blockage? Surprisingly, the coronary arteries are completely normal. So the cardiologist is stunned because he doesn't know what is this condition that's mimicking the heart attack. We do this MRI test, and there is a particular way that this condition presents that tells us what you're dealing with is this condition. And what it is, if I show you an example, if you look at the top end of the heart, you've got this narrowing because the contraction is preserved. And if you look at the bottom of the heart, it's not moving. This condition was first described by the Japanese in the 1990s, and they called it with a funny name. It's called Takotsubo. And what Takotsubo translates as is the octopus pot. And this condition, the way that the cavity deforms itself, looks very much like that octopus pot. In the West, we just call it the broken heart syndrome. What do you do about it? Well, you give it time. That's all it needs. The heart mends itself. And this is the same patient 3 months down the line, and you can see that ballooning of the heart has now returned back to its normal state, and the contractility is much better. In fact, it's normal. So this is a condition for which you definitely need imaging, and MRI is what you want to opt for. Now, I told you the valves are very necessary to make sure that the blood is flowing in one direction. Now, this is an example of a leaky valve. And so the heart is trying to squeeze the blood to go forwards. And that black jet indicates that the blood is coming back into the chamber because the valves are not functioning properly. In the past, when you had this kind of disease, the only way to sort it was by doing open heart surgery. Similarly, you can have valves that don't open because the leaflets are stuck together. Again, in the past, the only way to treat these conditions was by putting a heart valve. Now, this is an example of a patient who has had 2 heart valves, and you can see both of these heart valves are on the left, and you can see very clearly the leaflets moving. This patient has had this test for some other reason, not for malfunctioning valves. Great. Can we now do something without opening the patient? And the answer is yes. The interventional cardiologists are now trying to treat some of the conditions, not all, but some of the conditions with valve disease by doing the procedure under local anesthetic. Again, it's the same old threading of the catheter from the groin or from the arm. This is an example, and as you watch that image, X-ray image, you can see the valve being deployed within that balloon. And again, this procedure cannot be done blindly. Unlike the surgeon who can see the valve, the interventionalist cannot see anything. So we are there to help him either with an echocardiogram, and the probe that you see on the left-hand side of the patient, the tube-like structure, is the probe of an echo machine. All of these procedures get done either with an echocardiographer or a doctor who specializes in echocardiography. In my hospital, for these patients, I also do a CT scan before they have this procedure. And this is not a routine application, this is an off-piste application. We've done about 30 cases, and every time the CT scan was right in predicting at what angle the catheter needs to go in order to have a successful deployment. So you can see how powerful the technique is. Now, cancer is always in the press. Good thing for the heart is cancers of the heart are very, very rare. And when I say rare, it's really rare as a hen's teeth. Primary cancers of the heart. This happens to be one of those. The name is immaterial. It happens to be something called a myxoma. But what I want to show you and draw your attention to is there is this big blob of tissue that should not be there. And you can see very clearly where the epicenter of this mass is. How far down the valve is it going? Where is it going into the other chamber? And if I stop the movie, I get a better idea of the structures that this is affecting. As a technique, this is very, very useful, not for visual representation and show and tell, but for the surgeons. They actually love sitting with the cardiac radiologist to go through this because they tell me that the imaging helps them to plan the surgery in their head. Now, unfortunately, this came out in one piece and that was a success story. Unfortunately, you do have aggressive cancers going into the heart, and this is an example. So in this case, the patient had cancer in the kidneys, far away from the heart you would think. But remember, all blood vessels in the body are connected. So the cancer cells walked up one of the blood vessels. On its way, it affected the liver, and that's the blue star. And then the pipe, as it goes into the heart, it went into the right side of the heart, and that's game over at that point. There are some cancers which have got a propensity to go to the heart. That includes breast cancer, lung cancer, cancers of the skin called melanoma. So we need to be vigilant. Just because we don't see it often doesn't mean it's never. And we use imaging in the context of looking for these spread of cancer to A, look to see how many organs has it involved. B, we want to know what is the relationship of this lesion, this mass, to the surrounding structures, and it helps the clinician to plan what would be the most effective form of treatment. Now, birth defects. Now, one of the very first slides I showed you the heart, which was sitting in the left side of the chest, and that's normal. But there are some people who can be born with their heart in the right side of the chest. And this is an example. The star points to the tip of the heart sitting in the right side of the chest. And this condition is called dextrocardia. The name is immaterial, but what you need to remember is not all of us are not put together like the next person. There are little variations that we all have, and as variations go by itself, this will not cause any problem. But the problem comes when this condition is associated with other birth defects, such as a hole in the heart. And in this example, there is the hole, and you can actually see flow of the blood between the two chambers. What's the problem with this? So what? Well, the so what is you've got the right side with the bad deoxygenated blood. You've got the left side with the good oxygenated blood. Because I've now got a hole between the two chambers, the blood is mixing between the two chambers, and therefore I will have less oxygenated blood to go to my brain, less oxygenated blood to go into my toes. So this is an issue and it needs to be sorted. Another thing that we can look for very clearly on imaging is within the blood vessels. In this example on the far right, the arrow points to something that is called, that's narrowing of the blood vessel. This is a very severe example, and I've got you a relatively normal looking vessel for comparison. Now, so what if the vessel is narrowed? Well, this is something that happens at birth, and as the person gets older, the defect gets much more evident. And it can give you high blood pressure. And the blood pressure is not going to be controlled by medication, because whatever you do, this is a mechanical problem. You're not going to be able to treat the patient with medication. They are going to need some form of active intervention. That's either surgery, or you go and put a balloon and make it big and put a stent to keep it open. Now, this is one of my favorite images. You all know about heart transplant. This is something that's incredibly rare. This is called a piggyback transplant. And the piggyback is these two hearts in one patient. So normally what happens is, if you've got a heart that's not working and you're deemed to be suitable for a heart transplant, in the UK, you go on a waiting list. I'm sure you all know that we've got a problem with transplantation scheme because we don't have enough hearts to go around. But that aside, we do between 180 to 200 cases of heart transplant a year. And in the worldwide, there are only 150 cases of piggyback transplant. So why would you want a piggyback transplant? It's much more complex procedure. That's why it's not common. So if you've got a native heart that's not working, what happens is, if you're fortunate enough to get a transplant heart, the native heart comes out, the transplant heart goes in, it gets connected to the blood supply, and that is that. Sometimes what happens is the native heart is so bad that it starts to increase the pressure in the lungs and the blood vessels in the lungs. That condition is called pulmonary hypertension. Once you have that condition, if you just replace your native heart with a transplant heart, it cannot deal with that increased pressure in the lung, and it'll fail almost immediately. So when you have that condition, you either have the option of heart and lung transplant, or you say, I will do the piggyback. And the piggyback, essentially, you can see is two hearts connecting to to common blood vessels. If you've never seen this before, it's amazing, because they have two different electrical activities doing two different things. But the youngest patient to have this was about, I think, 5, and she's doing very well. So, piggyback transplants, a medical marvel. Now, you've seen examples of this before. This is a condition where you get a tear in the blood vessel. Now, the tear can start in the level of the heart and just above the heart, and then it can spiral out of control, and you can have the tear going down the entire body. The problem with the tear is it creates an artificial channel within the lumen of the vessel. So you have one part of the vessel that will have the blood supply, and that is the blue arrow, and then you will have another part of the vessel that does not have the blood supply. Unfortunately for this patient, the bigger lumen happens to be the lumen with no blood supply, and you can see nothing is going into the kidneys, nothing is going into the legs. This is a patient who came in not with chest pain, but who came in with cold legs because he had lost the pulses. And unfortunately for him, we had to amputate his legs because there was no blood supply to the legs. Okay, now moving on, I'll give you some success stories. We know that atherosclerosis, the so-called plaques that harden the vessels and clog the arteries, is something that we are very interested in. Inflammation of the blood vessels is a common factor that connects risk factors, plaque progression, and plaque rupture. So, if only we can image the inflammation, we would be in a position to predict who is at a higher risk of heart attack, and once you have instituted some medical treatment, you can decide, is this patient responding to therapy? How do we do that? Very, very simple. This is from a group in Boston, and what they did was we showed on the top deck a PET CT, and there is calcium there, and that calcium was taking up a lot of the tracer. That indicates that there is a lot of inflammation. This is a nasty plaque. What do you do about it? Well, you put them on high doses of appropriate medication, anti-cholesterol medication called statins. And a few months down the line, and you see that the extent of the uptake of the tracer that you have injected has reduced significantly. This tells you whatever you are doing, it's working. So it's very, very useful for drug delivery. Can we then answer the first question? Can you predict who's going to get a heart attack? We think we are in a position now to do that. On the left is an image from the Edinburgh group who are using that one particular tracer. On the right is the Cambridge group. Jason Tarkin is a PhD student who is working with me, and we are using a different tracer. And what we are showing is you might have a lot of plaques in your coronary arteries, but all plaques are not equal. The plaque that's taking up these traces are the plaque that's vulnerable. And what I mean by vulnerable is this is the plaque that's going to rupture. This is the plaque that's going to lead to heart attack. And therefore, when we see this, we can predict this is the patient who is going to go on to develop heart attack, and therefore we need to do something very, very quickly. I've talked a lot about different tests, but there is always the white elephant in the room, and that is radiation. Now, why is radiation bad for you? Well, radiation is bad for you because if you have X-ray beams with energies that are penetrating and they go through the body, they get absorbed by different tissues and organs. And at a cellular level, radiation is capable of damaging the core, the very core of that cell, the DNA of the cell. Normally, if you've just had one examination and your body is healthy, you are able to repair the DNA damage. But should you have multiple glitches to the cell programming over the years, one can go on to develop cancer. And therefore, radiation, having recurrent radiation, is bad for you. Now, I'm going to give you an example to show you how much the radiation is actually worth. Before I do that, I'm going to tell you that we are marinating in radiation anyway. And that's the natural radiation. We're all exposed to the sun, the cosmic rays, the radon gas. This is a map of the UK, as you can see. Yellow is okay, brown is middling, red is you are on the higher end of the radiation spectrum. And as with everything else, Ireland happens to be a hot potato even on the radiation question. But Let's say this is the background radiation. It's about 3 millisieverts. That's the unit that we use to measure the radiation per year. How does that compare to a flight? A 7-hour flight, which is somewhere between London and Boston or even Dubai, is about 0.05 millisieverts. Okay? What happens if you then have a cardiac CT? There you go. If you just have a calcium score, that's about 10 to 20 flights. If you have a CT angio, and if you have it with the best machine, with the best person who is sitting there optimizing all the parameters, you are lucky enough to get away with 30 to 60 flights. If you are in a unit where the machine is very old and there is not much leeway for you to change any of the parameters, you're going to end up with more dose. This is the best possible scenario. What happens if I give you radio traces? And you can see it's a lot of flights. Hey, but we have MRI, no radiation. So, all is not doom and gloom. Now, I'm going to show you risk-benefit ratio. So, if radiation is bad for you, what is the level of badness? Can I tell you that? Well, we know, regardless of whether one has been exposed to imaging or not, the lifetime risk of having invasive, and by invasive I mean something that's really nasty, cancer, is 38% in women, 1 in 3 women, and 45%, 1 in 2 men. That is irrespective of whether you've ever been exposed to imaging. You then complicate the whole story and add a numerical attribute to this. There is a 5% excess risk of death from cancer if you get exposed to 1 sievert. But be careful. All this while I've been talking with millisieverts, and 1000 millisieverts is going to 1 sievert. Nobody in their right mind is going to give you that dose as a result of a CT scan. And in very simplistic terms, what do these numbers mean? If I give 20,000 people 1 millisievert, 1 of them will develop cancer. I agree, you don't want to be that one. The answer to that is think twice before you want a test. What can I do about it? Well, both as patient and as well as a doctor and as a radiologist. The first thing to consider is, will the outcome of the test that I am having really change the treatment? If the answer is no, why have the test at all? Why go and have a test for the sake of intellectual curiosity? The second question, are there tests that do not involve radiation? And if so, is this an appropriate test for the condition that I am suffering from? If the answer is yes, go for the alternate test, provided you can have access to it. The third thing is something that is my personal bugbear. You've had a test in one facility. You decide for whatever reason that you want to see a doctor in another facility. Please don't go and have the same test twice. It's waste of resources, but more to the point, it's giving you double the dose of radiation. The fourth thing, are there ways to minimize the radiation dose? And the answer to that is a resounding yes. I'm not going to go into the technicalities of it, but in the best of hands, you can minimize the dose and make it as low as reasonably possible. Finally, it's good practice, both for the patient as well as for the clinician and the radiologist, to keep a track of the record of radiation that the patient has received, because it's not the one-time radiation that's harmful, it's the cumulative effect of radiation that's harmful. Now, this is a hologram of the heart, and this is the only slide that I had to take from a colleague, and I took this from a PhD student at Imperial. The reason why I took it is it's a complicated image to begin with, and then you start to see, it's actually the heart. And sometimes, what does the future hold? It's actually hidden in plain sight. And we know medicine today, as we stand, nobody in their right mind would practice medicine without having echo, CT, and MRI. Unfortunately for us, we now have the drama of digital technology that new players are coming into our lives every day, and these all new techniques are all redefining the competitive landscape. And some of these techniques I'm sure you've heard of: augmented reality, virtual reality, 3D printing, holographic data. And then the big thing that I haven't spoken about at all, artificial intelligence. Okay, that very nicely leads me on to my one slide in artificial intelligence. And for those of you who don't know what it is, essentially we are trying to see if computers can do some of the things that a radiologist traditionally has been doing. There are two groups of thoughts on this. There is the one group which say this is going to be the future of mankind, let alone radiologists. And then there is the other group, the naysayers, saying it's going to be the death knell, the end of the human race. I think the answer is it's going to be somewhere in between. And I think it is true that as radiologists, artificial intelligence is poised to have a transformative effect on our lives. And so instead of fighting with the technology, I think we should embrace it and go with it. There are mind-numbingly tedious jobs that we do every day as a radiologist. Why not let the computer do those jobs and you free yourself up to do the things that the computer is not going to be able to do, such as not detect but infer. I think artificial intelligence is going to produce a lot of information. That's one kind of intelligence. The real intelligence is going to be how you distill that information and give the clinician a perfect answer to the question that they are asking you. So, I don't believe when I hear in the media that artificial intelligence will replace radiology. I think that's frankly not true. But what I do believe is this: radiologists who embrace the technology and who use artificial intelligence will be replacing those radiologists who do not use artificial intelligence. So where does that get us? Well, the first thing to say is we are at an interesting time in medicine, and I'm not talking about Brexit. We are at a time where we are transitioning from an emphasis that was based on quantity-based imaging to quality and value. And cardiovascular imaging has to evolve with this concept. I've shown you a lot of techniques, some of which provide you new information, some of which provide you complementary imaging data. And what you want from this incremental data is to be able to refine and risk stratify somebody's risk of developing a condition. You want to be able to diagnose the condition at an early stage, institute the appropriate treatment so that it improves their outcome. This requires cross-fertilization between heavily specialized areas of practice, such as imaging and computing, for example. And ultimately what you want to do, the goal is to give the right patient the right test at the correct time. And in order to do that, we need to make sure that we are critically, constantly looking to see what we do. I think you will all agree that cardiovascular imaging has had and enjoyed an unbridled access to the technological improvement. But although the doctors and patients are all enamored of technology, it is true that our expectations of these advanced imaging technology do not always match the real value that is delivered. So it's up to us as a community of radiologists to look in to see what we do, constantly make sure that we avoid duplication and do not do unneeded tests. I think we have not eliminated cardiovascular disease. There are still a lot of challenges to face, but the imaging that we have to look at the heart is extremely robust. And I am optimistic that there will continue to be imaging improvements that will only be for the good of the patient. I would like to finish my talk by acknowledging people who help me deliver what I do every day of my life. On the left is a group of people that I work with in Imperial. On the right is a group of people that I work with in Cambridge. I've just put, for the sake of making it short, just the names of those people who lead these units, but I know that there are team members, some of whom are in the audience today, and if I have not said that before, I would like to say I am very thankful that you help me do what I do. And there is just one more person that I'd like to thank, and that's Peter. He's not in the audience, but he's my partner, and every day he gives me constant support and encouragement, and without his help, I would not be doing what I'm doing. Thank you very much.